Dear viewers, in this lecture, I'm going to discuss something about interpreting the arterial and the venous waveforms. And these are very important, not only from the exam point of view, but also from the practical point of view. So this will cover a little bit of basics and the differences that is there in drawing conclusions from similar looking waveforms. Let us start with a case. A 50-year-old male hypertensive is admitted for suspected community-acquired pneumonia. The physician in the ER puts an arterial cannula and records the blood pressure, and the blood pressure is this, and he considers it as a hypertensive crisis. Now, how do you ascertain if the reading is correct? In order to know whether an arterial waveform is accurate or not, we have to do a test, which is the rapid flush or the fast flush test, also known as the square wave test, in which we either squeeze or pull the plunger of the transducer so that they're exposed to the pressure in the compression bag, which is nearly 300 millimeter mercury. And following that, once it is exposed, the waveform takes a square shape. This is the square shape it takes. And when the pressure is released, it oscillates for some time and comes back to its position. Now, this depends upon its natural frequency and the damping coefficient. Therefore, a distinct diacritic notch suggests that the system has good resolution at higher frequencies, or in other words, it is not overdamped. So normally, if it takes one or two oscillations, 1.5 oscillations to be precise, to turn it back to normal, if the number of oscillations are more than 2, then the system is underdamped. And if the number of oscillations are less than 1, then the system is considered to be an overdamped system. So this transducer, when it is briefly exposed to this pressure right from the counter pressure of the compression bag, so this can oscillate at its natural frequency. Therefore, this transducer systems need to have a natural frequency in excess of 24 Hertz in order to resolve the features of the arterial line trace, like the diacritic notch. Therefore, when a system is underdamped, as I said, and there will be more number of oscillations, two or more oscillations, and in these cases, there will be underestimation of the diastolic blood pressure and overestimation of the systolic blood pressure, giving to rise to an overestimation of the pulse pressure. The diacritic notch appears deep, and also this number of oscillations are more during the diastolic phase. So this is clearly visible. On the other hand, when the system is overdamped, there will be one or less than one oscillations. There will be an overestimation of the diastolic blood pressure and an underestimation of the systolic blood pressure. And therefore, there will be an underestimation also of the pulse pressure. And the diacritic notch, which was deep in an underdamped system, becomes absent in overdamped system. Let us move into the second case. A 50-year-old male was brought with a one-day history of chest pain, body aches, and shortness of breath. His symptoms worsens with cough and has no apparent alleviating factors. On arrival, his vital signs show a temperature of 101.1 degrees Fahrenheit, heart rate of 111. The arterial blood pressure is 87/40. Respiratory rate is 19. Saturation is 99% on room air. Now, looking at the tracing, the waveform of the arterial waveform, what is the abnormality that is suggestive? So this is nothing but a Pulsus alternans, because here alternate strong and weak bits are alternately pulsating. And this is because of alternating filling volumes. Greater diastolic volumes accommodated by increased fiber length causes more forceful contraction, greater stroke volume, and subsequently with reduced end systolic and therefore end diastolic volume in the next beat, there are weaker forces giving rise to this weak pulsation. So this Pulsus alternans is a harbinger of severe ventricular dysfunction and carries a poor prognosis, and particularly it can be seen in patients with heart failure, cardiomyopathy, or coronary artery disease. And these patients are at greatest risk for developing pulsus alternans. Now look into this. This is a 50-year-old male, a history of IV drug abuser, who was resuscitated after a sudden cardiac arrest and brought to the ER. So what abnormality is present in this arterial waveform? Look nicely, and you will see that here we get something, this is called the pulsus bisferiens, where there is a single central pulse wave with two peaks separated by a distinct mid-systolic gap. The early component, percussion wave, results from rapid LV ejection, and the late component, that is the tidal wave, reflects a reflected wave from the periphery due to arteries recoil effect. So this pulse is best felt in the peripheral arteries like the brachial and the radial arteries, although it is not so well felt in the femoral. Most commonly seen in mixed aortic disease with severe AR and Hookham. But the important thing to note is that it can remain silent in mild disease and can get pronounced by Valsalva's maneuver and the use of the drug amyl nitrate. The main distinguishing feature of pulsus bisferiens is that the two peaks are in the systole. So that is what it differentiates from the diacrotic pulse, because here the one is in the systole and the other is in the diastole. Let us look into this. A 60-year-old female was brought with chest pain and high BP, while the ECG and tropi were negative for acute coronary syndrome. So what is the abnormality in this arterial waveform? Now, you can very well see that the amplitude is gradually coming down, and then again it is going up, reaching a plateau, and then again starts coming down. Now, this is what you get in pulsus paradoxus, which is characterized by a systolic pressure drop exceeding 10 millimeter of mercury during inspiration, commonly associated with pericardial diseases, notably cardiac tamponade and constrictive pericarditis. Many disease states apart from pericardial pathology may lead to pulsus paradoxus. The most common among them is severe asthma or COPD. Now, this pulsus paradoxus is in non-pericardial disease typically presents with a decrease in both systolic and diastolic blood pressure, whereas pulsus paradoxus in pericardial disease presents with a decrease primarily in the systolic blood pressure with a minimum impact on the diastolic blood pressure. Now, this is one way of distinguishing the cause of pulsus paradoxus to be either due to a pericardial or a non-pericardial cause. So overall, when you see in an arterial line, you can quickly do a first flush test and see whether the system is optimally damped or underdamped or overdamped, and look into the various waveforms, look into their characteristics to have a guess on the underlying condition the patient might be having. In addition to what the pulses I said, there is one called pulsus parvus attardus, which is a low amplitude pulse with a slow rising and a late peak. And this is something which we notice in severe aortic stenosis. Next, I am coming to the interpretation of the normal CVP waveforms. We know that in the CVP, there are three positive deflections or three positive waves, which are A, C, and V, and the two negative waves or the downward moving waves, which are X and Y. So A is because of atrial contraction. C is because of tricuspid valve elevation into the right atrium. The V is because of back pressure valve from blood filling the right atrium. X descent is because of downward movement of the contracting right ventricle. And Y descent is because of the tricuspid valve opening during the early ventricular diastole. Now look into this case. A 25-year-old female with history of intercurrent viral illness presents with syncopal attacks for since a day. And here, if you see something like this is because the atrial contraction is responsible for the A wave, and you can find that there are no A wave in the CVP tracing, as well as you can see from the arterial tracing, this is a AFib, atrial fibrillation. So the causes of atrial fibrillation can be both cardiac and non-cardiac. Among the non-cardiac causes, the important ones are alcohol intoxication, drugs, pulmonary embolism, hypoxia, CVA, defibrillation, electrolyte abnormalities, trauma, pneumonia, and many more. So whenever there is a newly diagnosed atrial fibrillation, the case is encountered in the ICU, there are certain steps of clinical assessment. In the first step, we have to assess the hemodynamic stability, and if the patient is unstable, there may be a need for urgent cardioversion. In the step 2, we have to go for rapid rate control and rapid conversion in sinus rhythm. Once it occurs, we have to optimize and follow up. In step 3 of the second clinical assessment, we have to, if the rate control is achieved, we have to optimize. Otherwise, if there are patient is symptomatic, we will have to further evaluate. Now, the evaluating strategy in cases of atrial fibrillation lasting for more than 48 hours, or when the duration is uncertain and patient has not received anticoagulation, we have to exclude atrial thrombi. We can do that by TE or by even normal echocardiography. And after that, we can have to consider for rapid conversion to sinus rhythm. Once it is converted, we can optimize and follow up as per necessity. And the third clinical assessment is to look into the adequacy of the hemodynamics. And if the hemodynamic is still not adequate, patient may require advanced ICU management, which may again vary from ICU to ICU. So these are the three important steps of clinical assessment that one needs to know while encountering patients of atrial fibrillation and newly diagnosed patients in the ICU. Now, this is important because atrial fibrillation is the most common arrhythmia in the ICU, and it can precipitate hypotension and heart failure. Coming to the next case, a 25-year-old female recently underwent MVR and presents with chest tightness and hypotension. So if here you can also see clearly there are two distinct forms of CVP waves, one which are reasonably taller and bulkier on the left, and the shorter ones are onto the right. And likewise, you can see that the tracings of the arterial line are also varying in their peaking. Now, this is what is called the junctional rhythm. In junctional rhythm, the atrial contraction occurs at the same time as the ventricular contraction, which results in fusion of the A and C waves, and that is why they appear thicker and also taller. Now, the causes can be divided into either retrograde conduction of ventricular depolarization or asynchronous atrial activity. For the former, VTAC, junctional rhythm, and ventricular pacing seems to be the precipitating factor, while for asynchronous atrial activity, complete heart block, accidental reversal of atrial and ventricular pacing wears, etc., seem to be the culprit. So the consequence of incoordination between atria and the ventricles causes hypotension because the ventricles are robbed of substantial preload and they become empty. Let's move into the next case. A 30-year-old female with history of breathlessness for 10 years presents with syncope. So if you see something like this, you will find that the C wave becomes accentuated and fuses with this V wave because both are results of right ventricular contraction, and the V wave peak pressure is often the same as the right ventricular peak systolic pressure. And in here, the main pathology is the backflow of blood out of the right ventricle obliterates the normal X descent. So this is the basic physiology. Here you can see high and A and V waves are there, while deep and slow X and Y descents are there in the right atrial pressure curve for constrictive pericarditis. And to your right, the deep and plateau, that is, which is called the square root sign in the right ventricular pressure curve for constrictive pericarditis. Now here you can see that the Y descent is lost very much. The Y descent is lost or decreased because of limited ventricular filling, and there is a prominent X descent during the ventricular systole. So here you can see the prominent ventricular systole, that there is a prominent Y descent, prominent X descent. So this typically can be seen in pericardial effusion in contrast to other conditions. Now, one has to differentiate between, although we don't use pulmonary artery catheters too often in the ICU, this one should know the distinction between the waveforms. As you can see, the upslope of the diastolic portion of the waveform in case of right ventricle, as well as in the pulmonary artery pressure, that is because the pulmonary artery pressure has a downslope part of the curve. How to differentiate RBB from LBB? In right bundle branch block, characteristically, the arterial upstroke precedes the pulmonary upstroke, whereas in left bundle branch block, the pulmonary upstroke precedes the arterial upstroke. So you can clearly appreciate that. Now, pulmonary artery, as it traverses from the vein to the right side of the heart, and from the heart it moves to the pulmonary artery, so the pressure changes. And as you can see in this diagram, initially, as long as it is in the vein, in the right atrium, the pressure, the systolic pressure remains limited, so it's not much. And once it reaches the RV, then the systolic pressure increases, as we can see. And once it reaches the pulmonary artery pressure, the diastolic pressure also increases. And finally, when it is wedged, everything disappears and a single moving line appears on the screen. So this wedge pressure, one has to remember that it should be measured at end expiration and in several segments of the pulmonary vasculature, because otherwise it may be very difficult to comment upon whether that is correct or not. Thank you very much.